Hi everyone, I'm Conrad Fisher, and I'm an associate professor of medicine, physiology, and pharmacology at Touro College of Medicine in New York City, and I'm the director of educational development at the Jamaica Hospital System Department of Medicine. And I welcome you to our next section, which is infectious diseases. And as we group up the antibiotics, looking at the principles of answering the questions, we're going to be able to see that things like the radiologic test is never the most accurate test, and that's common between all the different infectious diseases questions. And how do we break things up into the beta-lactam antibiotics, the fluoroquinolones, and aminoglycosides, which always cover gram-negative rods, doxycycline, which is always a specialty item now, chlamydia, rickettsia, a few things like Lyme disease, Bactrim, trimethoprim sulfamethoxazole, and I hate to have to torture you with trimethoprim sulfamethoxazole, but unfortunately, Step 2CK just doesn't take manufacturers' names, and Bactrim is a manufacturer's names. And finally, the beta-lactam beta-lactamase combinations, and when those are the answer. Since the organisms that are associated with diseases don't change and the antibiotics that treat them change, we can group things up and we can know one most important thing, that the antibiotics associated with each group of organisms, and that will really get us a lot of questions without having to understand a whole lot. In general, the radiologic test is never the most accurate test. That means that you cannot stain a CT, you can't culture an MRI, you can't get sensitivities on a nuclear scan. That's why the radiologic test, because it doesn't ever get you an organism, is never the most accurate test in infectious diseases. It could be in things like stroke or head trauma and looking for subdurals and epidurals, but not for cancer and not for infectious diseases. The radiologic test is never the most accurate test. Risk factors for an infection aren't as important as the individual presentation, meaning that the risk factors, such as a person goes on a camping trip, is not as important as, well, what's the presentation of that meningitis? And beta-lactam antibiotics are always the best efficacy. That means when you're presented with the choices of a set of antibiotics and you want to choose what is the best initial therapy, you don't choose based on adverse effects. You choose based on which will most effectively kill the organism. The next set of antibiotics are beta-lactam antibiotics, of which we have the penicillins, cephalosporins, carbapenems, and aztreonam. All of these are beta-lactam antibiotics. Therefore, all of them work as cell wall active agents. The penicillins can be broken down into regular penicillin, which is a penicillin G, which is intravenous, VK, which is oral, and benzathine penicillin, which is a long-acting intramuscular version, which we use for syphilis. Penicillin in general is useful for viridans group streptococci, which are found in the mouth and cause only endocarditis. They're useful for Streptococcus pyogenes, which is the cause of erysipelas, glomerulonephritis, which is the cause of group A beta hemolytic strep, which is the synonym for strep pyogenes, which is also streptococcal pharyngitis. It's useful for oral anaerobes, though not as effective as clindamycin, and for syphilis in general. Syphilis was used by treatment with penicillin in 1941, and so it is today. And penicillin resistance has never been described in syphilis. Leptospirosis, which is an infection, it's a zoonosis. These leptospira causes liver and kidney disorder, liver and kidney. It's diagnosed by serology and treated with penicillin. Ampicillin and amoxicillin are fundamentally the same molecule. They just get a little bit of a difference. One is because ampicillin is intravenous predominantly, and amoxicillin is oral. But other than that, they are the same antibiotics, so therefore they cover the same organisms. They'll cover the same organisms between each other, and they cover the same organisms as penicillin, and we add E. coli. That's why we can use it for urinary tract infection in pregnant women, because all beta-lactam antibiotics are safe in pregnant women, and this has been used for pregnant E. coli for a long time. Lyme disease or some of the gram-negative bacilli. Now, not too many, but a few. The gram-negative bacteria that are covered by amoxicillin are Haemophilus influenza, E. coli, Listeria, and Proteus. Salmonella. All these are covered by amoxicillin, or HELPS as an acronym. Penicillins are the answer, as which of the following is the best initial therapy? In which circumstances? They're the answer to the best initial therapy for otitis media, for dental infections, and endocarditis prophylaxis. Now, we're not doing much endocarditis prophylaxis anymore, but dental work with blood. Bloody dental work, if you have a person with previous endocarditis, prosthetic heart valves, transplant recipients, and the rare person who's got unrepaired cyanotic heart disease. So, even though the indications for prophylaxis are very restricted, this is still the drug of choice for endocarditis prophylaxis. We use it for Lyme that is limited to rash, joint, facial, rash, joint, facial, rash, joint, facial. CNS Lyme and cardiac Lyme are best treated with ceftriaxone. Also could use it for urinary tract infection of pregnant women because all beta-lactam antibiotics are fundamentally safe in pregnancy. And the other thing that we use penicillins for is Listeria. Listeria monocytogenes, such as an immunocompromised person with meningitis. And finally, enterococci. Enterococci are not covered by any form of cephalosporin, so no cephalosporin covers an enterococcus. However, penicillins, and particularly ampicillin and amoxicillin, definitely cover enterococcus, particularly when used in synergy with a aminoglycoside. The anti-staphylococcal penicillins are oxacillin, cloxacillin, dicloxacillin, and ampicillin, ox, clox, dicloxanaf. They cover cellulitis and skin infections, which is from sensitive staphylococcus. They won't cover MRSA, but sensitive staphylococcus. Endocarditis, meningitis, bacteremia, when it occurs from staphylococcus. We're not saying that meningitis is most commonly caused by staphylococcus. We're saying that when the meningitis does happen from sensitive staphylococcus, these are the drugs to use. These drugs are superior to vancomycin when the organism is sensitive. When the organism is sensitive, they are better. That's why they're better for osteomyelitis and septic arthritis when it's proved sensitive. Remember, they will not be effective against MRSA or enterococcus, but when the organism is sensitive, they're better than vancomycin. When we refer to oxacillin, cloxacillin, dicloxacillin, and nafcillin, we are referring to what's either known as anti-staphylococcal penicillins, penicillin ACE-resistant penicillins, but that is the class that methicillin was originally in. But we never use methicillin. Methicillin itself is never right, because methicillin causes allergic interstitial nephritis and renal insufficiency. When we say methicillin sensitive or resistant, we mean oxacillin sensitive or resistant. These other penicillins, piperacillin, ticarcillin, are not for staphylococcus by themselves. They're gram-negative drugs like E. coli, Klebsiella, Enterobacter, Citrobacter, Morganella, Pseudomonas. And that's what's added with these. They are anti-pseudomonal penicillins as well. They are great drugs, and they're first-class drug to piperacillin to add in for the biliary system. They really go into that liver a lot, the piperacillin especially. They don't cover staphylococcus unless you add a beta-lactamase inhibitor to them. These are GI drugs because cholecystitis and ascending cholangitis happen from E. coli going up into the biliary system. Pyelonephritis with E. coli going up into the urinary system. Bacteremia, severe life-threatening gram-negative, severe life-threatening bacteria, gram-negatives, hospital-acquired ventilator-associated pneumonia. Well, that's because the hospital's filled with gram-negative evil. And therefore, if it says a person had recently been hospitalized or had just finished being in the hospital for a week or has been on a ventilator for more than 2 or 3 days, you've got to use a gram-negative covering antibiotic for that hospital or ventilator-associated pneumonia. These are not the only drug for neutropenia and fever, but they are two of the drugs for neutropenia and fever. And neutropenia is defined as an absolute neutrophil count less than 500. An absolute neutrophil count less than 500, piperacillin, ticarcillin. The anti-pseudomonal penicillins are piperacillin, ticarcillin, azlocillin, and mesocillin. They will cover streptococci and anaerobes, but they're not the answer for infections exclusively from those organisms. They would be used for people who have gram-negative rods, gram-negative bacilli. If it's only streptococcus and anaerobes, we would use a narrower agent. And we generally use these agents in combination with a beta-lactamase inhibitor such as tazobactam or clavulanic acid. Tazobactam and clavulanic acid add staphylococcal cover. If the question describes a person with a history of penicillin allergy, can you use a cephalosporin? And the answer is, depends what the reaction is. If it is a rash, the answer is absolutely, because the amount of cross-reaction between penicillins and cephalosporins is very small, barely 3 to 5%, probably less. Oh, I heard it was 10%. You're wrong. So if it was just a rash, we use cephalosporins all the time. If it is anaphylaxis, no, switch off of beta-lactams. Anaphylaxis, switch off of beta-lactams. All cephalosporins in every class, in every group, 1, 2, 3, will cover group A, B, and C streptococci, viridins group streptococci, E. coli, Klebsiella, and Proteus. These are all easy to cover with all cephalosporins. Now, Listeria, MRSA, and Enterococcus are definitely resistant to all forms of cephalosporins. We have one exception with ceftaroline for MRSA. Other than that, everything else is resistant. Going to be ineffective encephalosporins for MRSA except ceftaroline. So these are agents that cover lots of gram-negatives and lots of staphylococcus with these few exceptions. If the case describes a rash to penicillin, answer cephalosporins. This is very hard to dislodge from people's brains. That's why I'm repeating this. If the case describes anaphylaxis, use a non-beta-lactam antibiotic. You don't have to agree with what I'm saying. You can agree with other things with your attending on the floor, but when you get to step 2CK, just answer what I'm telling you. First-generation cephalosporins such as cefazolin, cephalexin, cephedrine, and cephadroxil are the first generations that are used to treat staphylococci when it is sensitive staphylococci. From methicillin, which means oxacillin sensitive, which also means cephalosporin sensitive. If you're sensitive to oxacillin, you are automatically sensitive to cephalosporins. They also will cover streptococci. Of course, remember, no cephalosporin will cover enterococcus. No cephalosporin will cover enterococcus. It will cover also first-generation cephalosporins will still cover some common gram-negative bacilli, such as E. coli, but they're not anti-pseudomonal. They are very, very useful agents for osteomyelitis, septic arthritis, endocarditis, and cellulitis, which are predominantly staphylococcal infections. Second-generation cephalosporins are the cefotetan, cefuxetin, cefaclor, cefprozil, cefuroxime, loricarbef. Well, cefuxetin and cefotetan, these are the drugs for PID. They're the only two anaerobes covering drugs and cephalosporins. They're the only two cephalosporins that cover anaerobes, cefotetan and cefoxetin. That's why we use them for pelvic inflammatory disease and the GI tract sometimes. Second-generation cephalosporins are hard to understand because they cover the same organism as first-generation cephalosporins. And they had some coverage for anaerobes and a little bit more gram-negative coverage, but they're just a little bit extra to the first-generation cephalosporins. First-generation cephalosporins cover staphylococcus and streptococcus as long as it's methicillin sensitive, which is say oxacillin sensitive staphylococcus. Second-generation cephalosporins as a group will cover the same things and only add. Remember, there's nothing lost when you go from first generation to second generation. There is nothing lost in terms of coverage. You just add gram negatives, and for some of them, cefoxetin and cefotetan, you add anaerobes. This is why Cefotetan or cefoxin is the best initial therapy for pelvic inflammatory disease for PID, combining it with doxycycline. But, here's it. Ready. Cefotetan and cefoxin increase the risk of bleeding. Really? I never heard of that. Yeah, really. They can give a disulfiram like reaction with alcohol. No kidding, I never heard of that. Cefuroxime, lorcarb, cefprozil, and cefaclor. These drugs have been used for bronchitis for a long time because we consider them to be very much in the respiratory infections, bronchitis, otitis, sinusitis. They are not the number one drug for pneumonia. They are not number one for pneumonia, but they're used for respiratory infections such as you see here: bronchitis, otitis, sinusitis. How does coverage change or expand with third-generation cephalosporins? The third-generation cephalosporins, ceftriaxone and cefotaxime, these drugs are essentially identical in their coverage. Ceftazidime adds a little bit of gram negatives. Now, this is a section that I'm going to be purposely more repetitious because these drug names are so similar. You've got to have some repetition to understand that ceftriaxone is first line for pneumococcus, including partially insensitive organisms. That's why ceftriaxone is the drug of choice for meningitis and for community-acquired pneumonia in combination with macrolides or doxycycline. And that's why cefotaxime can be used for meningitis as well. We use them for gonorrhea, and as a matter of fact, they are superior. Ceftriaxone is considered superior to quinolone. Cefotriaxone and third-generation cephalosporins are superior. And we can also use them for Lyme, such as heart block or endocarditis, Lyme meningitis, Lyme heart block, or endocarditis. Finally, we avoid ceftriaxone in neonates because the neonates don't have an intact glucuronidation system. That's why ceftriaxone has not always been the number one thing for neonatal meningitis because of the impaired biliary metabolism. Now, that's not impaired in terms of a disease. It's impaired in the sense that it needs time to develop. Cefotaxime is a third-generation cephalosporin, and it is useful for the same things that we would use ceftriaxone for, which means it's an outstanding CNS drug for meningitis and also for pneumococcus and pneumonia. It is superior to ceftriaxone in neonates because it does not require the glucuronidation in the liver. It's very good for spontaneous bacterial peritonitis because people with spontaneous bacterial peritonitis generally have defective livers, and cefotaxime does not require hepatic metabolism. Ceftazidime is superior to both of these agents in terms of its pseudomonal coverage. Cefepime is a fourth-generation cephalosporin. It has better staphylococcal coverage compared to the third-generation cephalosporins. That's why it's considered to be a different generation. It goes like ceftazidime plus staphylococcal coverage. This is an excellent agent for neutropenia and fever, and for ventilator-associated pneumonia for people who are in hospital and extremely ill and have healthcare-associated or hospital-acquired pneumonia. Now, ceftaroline is the only cephalosporin to cover MRSA. As such, is a unique agent. It's a must-know drug. Ceftaroline is the only MRSA-covering cephalosporin. The exception for the coverage in that agent, though, is it won't cover Pseudomonas, but in terms of it covering MRSA, it is like adding vancomycin to ceftriaxone. Vanco plus ceftriaxone would have the same coverage as ceftaroline alone. The carbapenems are imipenem, meropenem, ertapenem, and doripenem. They cover gram-negative bacilli, particularly the ones that are extremely resistant. They cover anaerobes. Matter of fact, they have the same level of anaerobic coverage as metronidazole. They cover streptococci and staphylococci, but if you had exclusively an infection with streptococci and staphylococci, you would not use these agents alone. They are outstanding for neutropenia and fever, and all of them except ertapenem cover Pseudomonas. Ertapenem differs from the others in that ertapenem is the only non-anti-pseudomonal carbapenem. Aztreonam is the only drug in its class. It's a class of monobactams, the beta-lactam ring hanging out there alone amid side chains. It's the only monobactam used, and it is used exclusively for gram-negative bacilli, E. coli, Enterobacter, Citrobacter, Pseudomonas as well. It will cover Pseudomonas. but it's exclusively E. coli, Enterobacter, Citrobacter, Morganella, Pseudomonas cerevisiae, the aerobic gram-negative rods. And as an added special feature, there's absolutely no cross-reaction with penicillin, even though, as Trianam is a monobacterium, there is no cross-reaction with penicillin. Quinolones. There are a lot of them, about 10 of them, but these are the main ones we use, and a lot of them have been discarded. So I'm very careful about protecting that real estate in between your ears. So therefore, I'm not going to tell you about anything except ciprofloxacin, gemifloxacin, levofloxacin, moxifloxacin. These are number one gemi, levo, moxi for community-acquired pneumonia, including penicillin-resistant pneumococcus. Yeah, now Cipro's not for pneumococcus, but gemi, levo, and moxi for sure. They all cover gram-negative bacilli. They all cover. So again, Cipro's not so much for pneumococcus. Cipro's not for pneumococcus, but the others all are, and they all cover E. coli. That's why every form of quinolone will cover the urine. They all cover the urine. They all cover E. coli, Klebsiella, Enterobacter, Citrobacter. Yes. You should expect to have to go over the antibiotic section 2 to 3 times. There is no one that can get this on the first time. There's too many names, like learning a whole new language. If I wasn't me, I wouldn't know them. Ciprofloxacin is the number one drug for cystitis, bladder infections, pyelonephritis. As a matter of fact, you can send someone home for pyelonephritis on ciprofloxacin, and when the question says a person has pyelonephritis with an uncomplicated pyelonephritis and they have E. coli in their urine, what is the next best step? IV this, IV that, or oral ciprofloxacin? The answer is go home on oral ciprofloxacin. And the question, which I rarely have to cover here, which is the quote-unquote cost-effectiveness of medicine, is that if you have a person who can be treated successfully, equally, safely, in the privacy of their own home, instead of catching MRSA in the hospital, that's a mighty fine thing. So pyelonephritis, home on oral ciprofloxacin. Moxifloxacin is not as much for urine and cystitis, although it does cover E. coli. Moxifloxacin is our main drug for the lung. For the lung. We use that for the lung for community-acquired pneumonia. It's also for diverticulitis and GI infections. Now, moxifloxacin will cover anaerobes, but particularly we like to combine these drugs with metronidazole. So these are much better if combined. And that's why these quinolones, when combined with metronidazole, except for moxifloxacin, which will cover anaerobes, these are great drugs for diverticulitis. But moxifloxacin, what a weird name, right? Can be used as a single agent for diverticulitis without metronidazole. The others are this: Cipro for the gram-negatives, metronidazole for the anaerobes. Cipro for the gram-negatives, metro for the anaerobes. Gemifloxacin for the gram-negatives, metro for the anaerobes. Levofloxacin for the gram-negatives, metronidazole for the anaerobes. Moxifloxacin, single agent. All boards, all steps, love adverse effects. And they love adverse effects because they're clear. They're clear and they don't change. So you think sometimes, some of you, that the questions are going to be tricksy. They're going to game you. They're going to try and make you fail by asking you thin slices of bologna. But that's not the fact. They simply want you to know, hey, do you understand that quinolone shouldn't be used in kids and shouldn't be used in mothers? They cause bone growth abnormalities. Keep them off, particularly if you have an alternative. Now, if they described some weird case that said basically a woman has gram-negative bacteremia and the only thing she's sensitive to, the organism is sensitive to, is a quinolone, you would use it because efficacy beats adverse effects. But if you have an organism that's sensitive to 3 or 4 drugs, and this drug causes potential bone growth abnormalities, then you'll use the other drugs in a pregnant woman or a child. It causes tendinitis and Achilles tendon rupture. It inhibits osteoclasts and osteoblasts. See, quinolones concentrate in the bone. They concentrate in the bone. They concentrate in cartilage. And that makes them bad in pregnancy, but it makes them good in osteomyelitis. Gadifloxacin is removed because of glucose abnormalities. Why am I telling you about something that's bad? Because it's a clear question. Adverse effects are mandatory for you to know because the questions don't change over time. Therefore, some of the clearest questions you'll get on antibiotics are adverse effects because it's a lot easier to write, review, and audit that question. There's no disagreements. This picture is to remind you of the person on the left has ruptured their Achilles tendon. It caused Achilles tendon rupture because it inhibits osteoclasts and osteoblasts. No, it's not a misspelling on the gentamicin with an I and every other mycin with a Y. Don't ask me why. Or I should say, in this case, don't ask me I because it's gentamicin and aminoglycosides. These are the three that are on the market that we're going to worry about. Aminoglycosides are old drugs. They've been around since the 1950s, and they're essentially gram-negative drugs. That is to say, bowel urine bacteremia, ascending cholangitis, because that comes up into the biliary system from the bowel, gram-negative bacilli. And let's say it again. E. coli, Enterobacter, Citrobacter, Morganella, Pseudomonas, and Serratia. Again, E. coli, Enterobacter, Citrobacter, Morganella, Pseudomonas, Serratia. Those are the Enterobacteriaceae and Pseudomonas. And they are, however, synergistic with Staphylococcus and Enterococcus because basically they're synergistic with beta-lactams for Enterococcus and Staphylococcus. You wouldn't use them alone. They're synergistic. And what that means is the beta-lactam antibiotics, which blocks penicillin binding protein, breaks down the wall, bursts the wall, and then let's close up the breach with our aminoglycosides and kill the ribosome. Yes, the beta-lactam antibiotic knocked a hole in the wall, and then the aminoglycoside rushed through the hole in the wall and destroyed the ribosome. Synergy. When are they the answer? They are the answer for gram-negative bacilli and synergistically with Staphylococcus and Enterococcus with zero anaerobic coverage because they need oxygen to work. These drugs need oxygen to work. Now, super clear question, of course, is that they're nephrotoxic and ototoxic. They damage the tubular cells, they cause acute tubular necrosis, and they damage the hair cells in the inner ear. So much so, as a matter of fact, that if gentamicin was invented in the year 2012, this drug wouldn't get approval probably because of the toxicity. But the standards for approval are harder now than they used to be. Quite toxic compared to other drugs, but effective. Doxycycline is a great drug and drug of choice for chlamydia. Doxycycline and azithromycin for chlamydia. Lyme disease, it will cover Lyme, but not all Lyme. Lyme that's a Lyme rash, minor. Joint, minor. Yeah, joint, minor. Yeah, it is. Facial palsy, seventh cranial nerve palsy. The most common miscommunication about this is that when I say later on that ceftriaxone is for CNS Lyme, ceftriaxone for Lyme of the central nervous system, but doxycycline is for the seventh cranial nerve palsy. It's because the seventh cranial nerve palsy is not the central nervous system. That is a cranial nerve that counts as peripheral. That's why you can use doxycycline for the Lyme. Now I'm going to add something here that may be a little confusing, so I'm going to say it twice, which is to say that MRSA of the skin can be treated minor MRSA infections, doxycycline, trimethoprim sulfa, clindamycin. Minor MRSA infections. That's skin. That does not mean MRSA in the blood. It doesn't mean MRSA bacteremia. It doesn't mean MRSA in the CNS. Doxycycline can treat minor. I want you to have 100% certainty that if you study this a couple of times, you will get it. It cannot be obtained on the first time. Doxycycline will cover rickettsia, all of them. Therefore, in step 2, we suggest you not learn anything beyond simply understanding that rickettsia is diagnosed with serology, ELISA's Western blots, because you can't see it on a gram stain. It is intracellular rickettsia, too small to be seen on a gram stain. It's inside the cell. So for you, it's going to be only Rocky Mountain spotted fever, ELISA, Western blot, serology, treat with doxycycline. is for penicillin allergic persons, but only, see how that's capitalized, only primary and secondary syphilis if you're allergic to penicillin. Most common wrong answer, saying desensitize. Don't desensitize primary and secondary. That's penis and skin. Don't desensitize penis. You desensitize if it's CNS or pregnancy. CNS pregnancy, but not for primary and secondary. Doxycycline is also used for Borrelia, like Borrelia burgdorferi for Lyme. Remember I said Lyme, rash, joint, skin, Lyme, facial, rash, joint, skin, facial. Ehrlichia, which is another type of tick-borne illness, and mycoplasma. Now, the adverse effects of doxycycline are some of the easiest questions you can get. Tooth discoloration, but I want to be 100% clear. If it's Rocky Mountain, you give the kid the doxycycline. It's better to be alive with stained teeth than dead or having brain damage or neurologic dysfunction with white teeth. So remember, efficacy is above adverse effects. That's why in this slide you see rickettsia beats adverse effects. It can cause some RTA, okay, proximal RTA, Fanconi syndrome, some photosensitivity, and esophagitis. That's pill esophagitis. Have your pills sitting up, drink a lot of water. Don't let them stay down there and irritate. It's a physical irritation of the pill against your esophagus. That's pill esophagitis. And this is more common than you think in older people, particularly people who don't drink enough. They get a little dry. They're a little dry. Grandma's a little dry. She doesn't wash her pills down, stays in the esophagus, and hurts her. Trimethoprim sulfamethoxazole, folate antagonist. You don't have to learn a lot of mechanisms of antibiotics for step 2CK, so that makes it somewhat easier for you. You just have to know when to use it. It's useful for cystitis, 3 days for uncomplicated cystitis, 3 days for uncomplicated cystitis. For pneumocystis pneumonia, now the organism may have had its name changed to pneumocystis jirovecii, but the infection is still pneumocystis pneumonia, both for treatment and prophylaxis. MRSA, trimethoprim sulfa of the skin and soft tissue. Minor MRSA. Again, not for bacteremia, not for the heart, not for the brain. Now, trimethoprim sulfamethoxazole, because of sulfa causes a rash, and this is about 10% of the population is sulfa allergic. Hemolysis, especially in people who have G6PD deficiency, it basically oxidizes your cells and causes acute hemolysis. Look for those bite cells and Heinz bodies on supravital staining. Bone marrow suppression, of course, because it's a folate antagonist. And here's how the question goes. It will say, hi, after rash, what is the next most common manifestation of the adverse effects? Bone marrow. Here it says, what drug should be avoided in someone who has folate deficiency or pancytopenia from folate deficiency? Which medication should be avoided? And the answer is trimethoprim sulfamethoxazole. Now, here's one extra thing here. We're just going to say one word because we're on the cystitis section. That's why nitrofurantoin is here. Yes, you could use trimethoprim sulfa, or you could use nitrofurantoin. They're not going to put them both in the same question for you because it's unanswerable. Here's the warning. If you see cystitis and there's nitrofurantoin and trimethoprim sulfa in the same question, look and see if the woman's pregnant. If you see cystitis and they're both in the same answer, look and see if she's pregnant. Nitrofurantoin is basically one indication. Cystitis. That's it, especially in pregnant women. Now, this is another rule of thumb. It's a Conrad Fisher rule of thumb for you. If you see two choices that look to be equal in efficacy, you're missing an adverse effect. If two answers for therapy look to be correct, you're missing an adverse effect. Beta-lactam ACE combinations mean the combination of a beta-lactam antibiotic, in this case only penicillins, because we don't have any drugs on the market that are a combination of a beta-lactam other than a penicillin. It is a beta-lactam penicillin and a beta-lactam ACE inhibitor, sometimes called a suicide inhibitor because it basically is destroyed in the process of inhibiting the organism. Now, amoxicillin and clavulanic acid, also known as augmentin, ticarcillin clavulanate, basically what happens is that the Beta-lactamase adds staphylococcal effect, staphylococcus activity, ampicillin sulbactam, known as unicin, and piperacillin tazobactam, sometimes known as zosyn. Now, I'm not telling you the brand names because I want you to answer them on the test. I'm telling you the brand names because if you are a third year medical student that has just finished several rotations, you'll probably hear the names referred to as augmentin, timentin, unicin, and zosyn. And so now I want you to retranslate out those drugs into these beta-lactam, beta-lactamase combinations. And in all cases, the beta-lactamase will add mostly staphylococcal effect. None of these antibiotics cover staphylococcus. They will only cover staphylococcus if you add the beta-lactamase inhibitor. And they only cover a sensitive staph, even with beta-lactamase inhibitor. They only cover sensitive staphylococci, no MRSA. We're going to switch now from saying, here's the antibiotic, what does it cover? And we're going to switch it to, here's the organism, what's the best initial therapy? Now, if you are learning this and there are exceptions to things, or somebody says, yeah, but not always, not always, that may be true, but you can't answer questions that way. We're talking about the 95% of the time. 95% of the time, if it's a sensitive staphylococcus and streptococcus, the best initial therapy is ox, clox, dicloxanaf, oxacillin and cloxacillin, dicloxacillin and nafacillin, ox, clox, dicloxanaf, ox, clox, dicloxanaf, oxacillin and nafacillin or IV, cloxacillin, dicloxacillin, or oral, oxnaf, IV. The other drug for staphylococci and streptococci is first-generation cephalosporin, cefazolin and cephalexin. Don't spend too much time thinking about why some have a PH and some have an F. That's just the way it is. Fluoroquinolones will cover some of the staphylococci, and that's particularly if you have a life-threatening penicillin allergy. Not ciprofloxacin, but levofloxacin, gadifloxacin, moxifloxacin. The macrolides, erythromycin, azithromycin, clarithromycin, erythromycin, azithromycin, clarithromycin are third line. Why? Why the third? Efficacy. They have less efficacy than oxacillin or cephalosporins. Less efficacy. And then after efficacy comes toxicity. Erythromycin is more toxic for the same reason that erythromycin is good if you have diabetic gastroparesis because it helps that forward motility. Erythromycin is bad if you're normal because it helps your forward motility and helps you run to the bathroom with diarrhea, or the other way around with vomiting. For oxacillin or methicillin-resistant staph, the primordial drug is vancomycin. In addition, there's linezolid, although linezolid as an adverse effect can have some reversible bone marrow toxicity. On which part of the bone marrow? The platelets, platelet inhibition. Daptomycin for MRSA. Daptomycin is not effective in the lung, Daptomycin is not for the lung because lung pH inactivates it and can cause some CPK abnormalities. Those are the adverse effects of daptomycin, but it's an MRSA drug that has outstanding efficacy. Tigecycline is its own class of agent. It's a glycylcycline. Wow, glycylcycline, tigecycline. It is a non-anti-pseudomonal gram-negative. It will not cover Pseudomonas, but it's like adding vancomycin to ceftriaxone. As such, tigecycline and ceftaroline have tremendous similarity. For minor MRSA infections of the skin, you can use those are treated with trimethoprim sulfa, clindamycin, or doxycycline. That's for minor MRSA skin infections. You would not be using trimethoprim sulfa, clinda, or doxycycline for MRSA in the blood, the brain, or for the heart, but you could use them for the skin. Anaerobes. Now, anaerobes, we're going to divide them up between the ones that are in your mouth, and mouth means respiratory because the lungs are sterile. Everything below the cord should be sterile. The cords is like your cervix. Everything above the cervix should be sterile. Everything below the cord should be sterile. So if you have anaerobes in your lung, they came from your mouth. And oral anaerobes, which say respiratory, the ones causing aspiration pneumonia, lung abscess, aspiration pneumonia, lung abscess, penicillins. Now, penicillins as a group. In this case, we mean penicillin G, VK, ampicillin, or amoxicillin. Now, not the penicillins of the ox, clox, diclox, and NAF. Those are staph and strep drugs. They do not cover any anaerobes. The ox, clox, diclox, and NAF, no anaerobe. No anaerobe for them. Anaerobes is for the penicillins that are penicillin G, VK, ampicillin, amoxicillin. Clindamycin also covers above the diaphragm anaerobes, and metronidazole as well. Now, metronidazole is mostly for GI. That is far preferable for GI anaerobes. That's for Bacteroides fragilis, yes. Now, this is the same way clinda and metronidazole can both be used in the vagina, and you could use clindamycin there as well because we'll cover the Gardnerella, and so will the metronidazole. And remember, metronidazole is safe in pregnancy. That was thought not to be the case for a long time, but now metronidazole is known to be safe in pregnancy. Now, the other drugs that will cover anaerobes, the piperacillin ticarcillin group, all the carbapenems, and second-generation cephalosporins of cefoxitin, cefotetan. Piperacillin ticarcillin will cover anaerobes, carbapenems, all of them, second-generation cephalosporins, and finally the beta-lactam, beta-lactamase combinations as well. Hang on, you're almost done. And now our last couple of categories. Gram-negative bacilli, such as in the bowel, peritonitis, diverticulitis, E. coli, Klebsiella, Leporius, Pseudomonas, Enterobacter, Citrobacter, Morganella, Serratia. Doesn't matter. They're all the same except Pseudomonas, really. So I say E, break them out into different names like Enterobacter, Citrobacter, Morganella, Serratia, but it doesn't really matter because the answers are the same. If it's step one microbiology, you'd learn differently, but please don't. Save your brain, would you? The bowel, peritonitis, diverticulitis, ascending cholangitis, cholecystitis, cholangitis. Cholangitis like pyelonephritis of your liver. Get a stone or a stricture, tumor or obstruction, blocking it, ascends up into your liver. Stone or stricture, tumor or obstruction, blocking it, ascends up into your kidney. Stone or stricture, tumor or obstruction, liver, kidney problems. All of these are covered with quinolones, aminoglycosides, the carbapenems, piperacillin, ticarcillin, aztreonam, and cephalosporins. Remember, with the exception of first-generation cephalosporins and Pseudomonas, wow, all 6 of these classes cover E. coli, Klebsiella, the Enterobacteriaceae, all of them. I know what you're thinking. What if you're asked to choose between them? And the answer is you won't. See, the wrong answers are going to be things that are really wrong, like vancomycin or oxacillin. It doesn't cover any gram-negatives. The wrong answers will be really wrong, trust me. Man submitted with E. coli bacteremia. What's the most appropriate step therapy treatment for this guy? You see what I'm saying? The wrong answers have to be really wrong. This should relax you. See, it's an IQ test. Which one of these is different from the other 4? Now, the reason I put in quinolones and aminoglycosides, carbapenems, piperacillin, ticarcillin, aztreonam, is because any one of them could have been the answer. You see, 5 out of 6 of these don't cover any gram-negatives. Now, what will the right answer be? Will it be the quinolones, the aminoglycosides, carbapenems? Doesn't matter. Doesn't matter. Point is, choice C is the right answer, no matter which one they give you. I'm just trying to have you relax so you understand that the wrong answers will be really, really wrong. Any one of the ones in choice C. Vancomycin simply does not cover any gram-negatives, neither does linezolid, doxycycline, nor clindamycin. They just don't cover gram-negative bacilli. None of them, except the ones in choice C.